Welcome to Perinatal Mental Health 101, part one of a two-part specialized training series by POEM of Mental Health America of Ohio, designed in partnership with CompDrug. This series was tailored for peer recovery supporters working with or aspiring to work with perinatal individuals. My name is Raquel Williams, and I currently serve as a Senior Collective Impact Manager for POEM, Perinatal Outreach and Encouragement for Moms, a peer-led, community-based program that provides mental health support to moms and birthing persons in Ohio. I am a licensed social worker, certified peer recovery support specialist, and survivor of perinatal depression and anxiety. I say that to say that while I am showing up here in a professional capacity, I am also showing up with lived experience, which may be referenced from time to time to support learning as we move through the content together.
My name is Ashley Sebula, and I am a perinatal program coordinator at CompDrug in Columbus, Ohio. CompDrug is an outpatient substance use disorder and mental health treatment facility that also has pregnancy and parenting services. I operate our perinatal linkage to care program that connects pregnant and postpartum people to treatment, resources, and support. I have over 8 years experience working with mothers and young children and 5 years of experience working in the recovery field. Alongside my professional experience, I also have lived experience as someone with infertility, navigating IVF, and recurrent pregnancy loss. Welcome to our training.
The goal of this session is to help you establish a foundational understanding of perinatal mental health complications, what they are and how they might present, as well as share with you how to appropriately address them with care and compassion. Today's content will focus on overviewing perinatal mental health and substance use, identifying risk factors and barriers to care, introducing screening and assessment, and understanding collaborative care and referral. When this training is presented with a live group, we typically take time to discuss community care practices. While you might be moving through this session independently, I still think it's important to note that these care practices are good for yourself. The topics within this training can be emotionally heavy and activating. You might engage with concepts, beliefs, or information that feels new or different for you. And as you take in the content and engage in peer support in a professional or personal capacity, it's important to be respectful, open-minded, and curious. Remember that we all bring histories that are personal to our individual lived experience, as well as perspectives that shape how we see and experience the world. Accept accountability for your personal beliefs and actions. Know when to speak up and know when to listen. Protect the confidentiality and privacy of the other peers you connect with. Their personal stories are theirs to share, but the lessons that you learn from listening to their stories are yours to take. And last but certainly not least, take care of yourself just as you aim to take care of others. Throughout our time together, you may hear a breadth of language being used. To ensure shared understanding, here are some frequently used terms related to perinatal mental health and peer support to familiarize yourself with. Perinatal. This is not to be confused with prenatal or postnatal. Perinatal refers to the period of time beginning in pregnancy and within the 12 months following childbirth. Peer support. This is emotional, informational, instrumental, or other help provided from one person to another or to a group of people with shared lived experiences. A perinatal peer is defined as someone who has experienced a perinatal behavioral health complication. So that is a mental health or substance use condition during pregnancy or the first year postpartum. A clinical professional. This is a healthcare provider who directly treats patients or provides patient care and has specialized training, typically involving a licensure or certification. Part 2 of this training series will discuss the important distinctions between clinical professionals and peer supporters. Cisgender. This is a person whose gender identity matches the gender they were assigned at birth. Not every person who experiences pregnancy or childbirth is cisgender, and this is an important reminder as we aim to provide peer support that is inclusive, compassionate, and affirming. Birthing person or pregnant person. We use these terms alongside or in place of mom or mother. It's an inclusive way to describe anyone who is able to become pregnant or give birth, including cisgender women, transgender men, non-binary, or other gender-expansive people. Substance use. This is the sporadic use of psychoactive substances. Substance use disorder. This is the pattern of substance use that involves impaired control, social problems, and physical dependence. Substance use and substance use disorder are sometimes used interchangeably, but note that they are different. Substance use disorder must be diagnosed by a credentialed provider. Cultural humility. Different than cultural competence, which might imply completion, cultural humility is a lifelong openness to learn. Understand your biases and work towards respectful, equitable interactions with people from different cultural backgrounds while being aware of power imbalances. Cultural responsiveness. We will discuss this quite a bit when it comes to best practices in providing perinatal peer support. It is a care or treatment that is sensitive and adaptive to the cultural context and lived experiences of Black and POC, or like other persons of color, as well as others whose cultural identity or community experiences shape how they give and receive care. As previously mentioned, people who experience pregnancy may identify as cisgender female, transgender men, and non-binary. Language like perinatal, birthing person, or pregnant people can be used interchangeably with maternal, mama, mother, and pregnant women to be more inclusive. Perinatal mental health peers should respect and celebrate all types of family configurations and be sure to ask and use the correct pronouns. Within healthcare systems, be mindful of heteronormative behaviors and encourage language that is inclusive, respectful, and welcoming. Women's stories can still be heard and centered, and language that acknowledges everyone doesn't remove cisgender women from parenting conversations. It helps all gender identities feel comfortable. If you'd like to learn more about gender identity, I encourage you to check out the Genderbread person at genderbread.org. There's a lot of helpful information there as far as language and terms, inclusive words to use go, as well as a deeper understanding of gender identity, expression, and sexual orientation. Before we get into the spectrum of perinatal mental health complications, let's first address a common misconception around them. Perinatal mental health complications are not the same as the baby blues. The baby blues are normal emotional up and downs associated with hormonal shifts in the first few weeks following childbirth. They occur in up to 80% of new birthing persons, and they can be categorized by tearfulness, mood swings, overwhelm, and irritability. Sleep deprivation and fatigue may be present, but the birthing person's overall mood is generally positive and they are bonding with their baby. With rest, nutrition, and support, the baby blues will naturally resolve itself within 3 weeks. To help assess whether or not a mom or birthing person is experiencing the baby blues or something a little bit more, consider the following statement. If there are severe emotions, an impact on the birthing person's ability to care for themselves or their baby, or it lasts longer than 3 weeks, it might be indicative of a PMHC or a perinatal mental health complication. At that point, we'd want to get curious and seek out some additional support. While we still have a ways to go, our understanding of perinatal mental health has grown in recent years. We now know that postpartum depression is just one of several conditions that a mom or birthing person may experience. Perinatal mental health complications, or PMHCs, refer to a range of conditions that can occur in not just postpartum, but during pregnancy as well. And while we might most be familiar with depression, it's actually quite common for conditions to co-occur. The risk and severity of these conditions are often impacted by social determinants of health, such as racism and discrimination, access to quality health care, access to affordable housing, the strength of one's support network, etc. PMHCs are treatable. However, they may not go away without proper treatment. As we discuss the signs and symptoms of PMHCs or perinatal mental health complications, remember that this list is not finite. There could be some overlap in symptoms and variations in person to person. Our job as peer supporters is never to diagnose. Use your understanding of PMHCs to better know when you or someone you're working with could use some additional support. Anxiety or panic might present as excessive worry and overwhelm. There could be shortness of breath, rapid pulse, dizziness, chest or stomach pains. Somatic or physical symptoms, such as these, are very common, especially in Black moms and birthing persons, who are more likely to report physical ailments in association with mental health challenges. With anxiety, the mom or birthing person might be experiencing distractibility, sleep disruptions, and guilt or shame. For those who have experienced pregnancy or infant loss, anxiety is especially common in subsequent pregnancies. Depression and anxiety can often co-occur, resulting in increased thoughts of self-harm. With depression, we want to listen for feelings of worthlessness, maybe expressed in statements like, "My baby would be better without me." Expressed feelings of hopelessness, disappointment, and overwhelm are all important to watch for when assessing risk of self-harm. Those navigating perinatal depression might also experience changes in their appetite, energy, and concentration. They might experience anger or rage, as well as a disconnection between themselves and baby. Post-traumatic stress disorder is common among those who have had traumatic birth experiences, such as physical complications during their pregnancy or childbirth, having a baby needing the NICU, emotional distress related to interactions with healthcare providers that left them feeling unsupported or powerless, etc. Those with PTSD might have flashbacks of the event or avoid things or places that remind them of the event. They may experience nightmares or other sleep challenges. Feelings of numbness, low mood, sadness, and even dissociation can occur. OCD, or obsessive compulsive disorder, is often misunderstood. Typically, it's associated with extreme organization or tidiness, but this isn't always the case, especially in the perinatal period. A mom or birthing person with OCD often engages in compulsive behaviors to reduce the anxiety they are experiencing, such as excessive checking on the baby to ensure they are breathing, which could be associated with sleep-related fears. OCD often presents with perinatal depression and anxiety. They might experience intrusive thoughts that are disturbing, repetitive, and difficult to control, often bringing them shame. When these thoughts cause the individual distress, they are considered ego-dystonic and should not be considered a medical emergency or cause for involving Child Protective Services. Intrusive thoughts can be misunderstood as a sign of psychosis, but it's very important to note the difference so we do not cause harm. Bipolar and psychosis, unlike other perinatal mental health complications, are considered a medical emergency. Moms and birthing persons experiencing psychosis experience a break from reality, and they might have thoughts of harming themselves or their baby, and those thoughts do not cause them distress. This is considered ego-syntonic. They might experience paranoia, hallucinations, delusions, and mood swings. With a lower occurrence rate and misrepresentation of perinatal mental health in the media, psychosis is often first detected by someone quite close to the mom or birthing person. If you're wanting to learn more about psychosis and the symptoms to look out for, visit the Policy Center for Maternal Mental Health. They have a free psychosis symptom checklist available for public use. Remember, your job as a peer supporter is not to diagnose, but to support individuals in accessing quality care and treatment. You don't have to remember all of the signs and symptoms to every perinatal mental health complication. It's uncommon that someone will discuss their mental health in clinical terms. Rather, you might hear someone say that they are feeling off or just not like themselves. Build rapport with whomever you are supporting, and through care and compassion, ask questions that will help you to discern whether or not additional support may be needed.
Perinatal substance use is defined as engaging in substance use during pregnancy and up to 12 months postpartum. This also includes the use of alcohol during pregnancy after a pregnancy is identified and or confirmed. Perinatal substance use became a hot topic during the crack epidemic in the 1980s and when the opioid epidemic started in the 1990s and peaked in the 2010s. However, substance use during pregnancy and postpartum is not a new phenomenon. Pregnant and parenting people have been using substances for centuries. An example of this would be substance use in the 1950s among mothers. The use of amphetamines, weight loss medications, antidepressants, Valium, sleeping pills, and seizure medications occurred. A notable difference between the perinatal population in the 1950s and today is that a majority of substances being used in the 1950s were legal and prescribed medications. Medications and supplements were not heavily regulated like they are in present day, and this led to medications being misused. Which brings us to our next topic, the difference between a substance use disorder and substance misuse. A substance use disorder has to be diagnosed by a licensed professional and meet the criteria outlined in the DSM 5. Substance misuse is taking a medication outside of the way it was prescribed. An example of this would be Adderall for people with ADHD. Someone may be prescribed to take one pill daily for their symptoms, but if someone is taking more than one pill daily, they are engaging in substance misuse. Important when talking about the populations using substances. It's important to use person first language to destigmatize substance use and humanize this population of people. I always like to say, we are people first, not what has happened to us. I'm going to concentrate on the words addict and baby born addicted. In the recovery community, we do not use the term addict to describe someone who has used substances or someone in long term recovery. We use the phrases person with substance use or person in recovery. I know that it is common for those in long term recovery to identify as an addict, and I think it is important to note that I do not correct or question how someone with lived experience chooses to identify. Now, moving on to the phrase baby born addicted. It is actually biologically impossible for a baby to be born addicted to anything, since they did not consent to the use of the substance they were exposed to. When referring to a baby with substance exposure, we instead say baby born with substance exposure or baby born with neonatal abstinence syndrome.
Now that we've discussed what perinatal mental health complications are, let's discuss prevalence. Perinatal mental health complications are the most common complication of pregnancy and childbirth, affecting 800,000 families each year in the US. Despite being more common than gestational diabetes, preeclampsia, and other medical conditions frequently discussed in pregnancy and childbirth, as they should be, mental health is still not widely prioritized in routine perinatal care.
It is important to note that when we discuss the prevalence of perinatal mental health conditions, we point out that it is vastly underreported due to fear, stigma, shame, and lack of education surrounding perinatal mental health. About 20%, or 1 in 5 perinatal people, will experience a perinatal mental health condition. Black women are 2 to 3 times more likely to experience a perinatal mental health condition compared to other subgroups. Up to 20% of people use substances during pregnancy, and less than 15% of perinatal people will receive treatment for their condition. Perinatal mental health conditions can have adverse health outcomes for the mother and the child. Suicide and overdose are the leading cause of death during the first year after birth. In fact, overdose is vastly more common during the postpartum period. A pregnant person's blood flow and metabolism increases during pregnancy, so their substance tolerance also increases. During the postpartum period, there are a lot of hormonal changes that occur rapidly after birth. One of these changes includes the change to metabolism and blood flow. it starts to go back to where it was pre-pregnancy. This means that if someone were to use the same amount of a substance they used during pregnancy during the postpartum period, then they are at a greater risk for overdose. Their tolerance will have decreased. We will discuss Child Protective Services in greater detail during part 2 of this training series. I will point out today that up to 90% of child welfare cases are linked to familial substance use in some capacity. I had worked with Fayette County here in Ohio a few years ago. In 2021, their local children's service agency had told me that about 49% of children residing in Fayette County were not living with their birth parent or parents. Listed on the screen are a list of risk factors. In the next few slides, we will dive deeper into systemic, social, and psychological factors. Listed on the screen are barriers perinatal people experience in receiving treatment and care. I'll highlight today transportation, housing, and language differences. Transportation remains one of the leading barriers to care. Over the last 5 to 10 years, insurance providers have increased accessibility to transportation to things like appointments and even access to food pantries. I have ran into some barriers with clients being able to receive transportation to things like an intake appointment through their Medicaid managed care plan. Some plans require you to be an active patient to receive a ride through Medicaid. It is difficult to become a patient if you cannot even make it to the very first appointment. I believe housing has surpassed transportation as a leading barrier to care. We are facing a severe housing crisis in our country. It is difficult to keep appointments if you do not have a safe place to sleep each night. I can, of course, only speak to Columbus, Ohio when talking about our housing crisis, but I will say from my professional experience working in this county, we have an overabundance of people who are unhoused as well as living in our shelter system. Columbus has become a diverse city with increasing populations of people of Hispanic origin, Nepali, Somali, and Haitian Creole, just to name a few. It is difficult to find a behavioral health provider, like a therapist, for example, who speaks a language outside of English. Many people may not feel comfortable to sit in a session where there is another person present.
Trauma is a real or perceived threat to your psychological or physical well being, either for yourself or for a person you care for. I often describe it as being in the eye of the beholder. What is traumatic for one person might not be traumatic for another, but those individual differences don't make it any less real. Different types of trauma can exist. Reproductive trauma might involve infertility, pregnancy and infant loss, a traumatic birth experience such as hemorrhaging or an unplanned C-section. Race-based traumatic stress is trauma experienced by individuals due to exposure to systemic racism, discrimination, and racial violence. Consider that Black moms and birthing persons are 3 times as likely to die due to pregnancy-related complications compared to white birthing persons. This is in large part due to systemic racism and implicit bias in healthcare settings. Consistent exposure to medical racism, either from firsthand experience or witnessing it through media, can lead to mistrust in healthcare providers and race-based traumatic stress. Early childhood trauma is probably the most widely understood. Look to the image shared here, the pair of aces. While some of this language used is outdated, it does a good job of representing the various experiences that could be considered traumatic for someone. For moms and birthing persons specifically, certain people might be at a greater risk for developing PTSD. Black, Indigenous, and other people of color, due to systemic racism, discrimination, and bias, so that race-based traumatic stress that I just spoke to. Those who have experienced pregnancy and infant loss. Individuals who have had perinatal and or fetal complications. People who have an unplanned pregnancy, or someone who has a history of trauma.
I have come across many perinatal people who have generational trauma. Generational trauma could be a parent engaging in substance or excessive alcohol use, abuse within the home, growing up in poverty, and much more. These events affect the children that are exposed and continue to be passed down to generation. When discussing generational trauma, I often use the show Shameless as an example. If you have not seen this show, I highly recommend it to see an example of generational trauma within a family. The show follows the Gallagher family that consists of Frank Gallagher, the father, who suffers from substance and alcohol use, and their mother, Monica Gallagher, who suffers from untreated bipolar disorder. They have a handful of kids, and the show follows each of the children's storylines and how their upbringing and parents impact their lives.
If you can, take a moment to pause this training and reflect on your learning so far. We have spent a lot of time discussing the multi-layer factors that might increase someone's risk of developing a perinatal mental health complication. However, part of being a positive peer supporter involves care navigation and the ability to identify existing strengths and supports for the people we are helping. Ask yourself, what systemic, social, biological, or psychological factors might be considered protective or even preventative factors for moms and birthing persons? As you take a moment to think about your answers or maybe write them down, I'll also provide a few examples to get you thinking. Adequate paid parental leave. Returning to work can be a huge stressor for new parents. Having more time to be at home can ease the transition, alleviate stress or worry, and even give them more time to engage in mental health supports as needed. Peer support groups. Pregnancy and parenting can be isolating. It's often helpful to talk with other moms and birthing persons who are on a similar journey with you. We always tell people that it takes a village. And I think there's parts of that can be true. The good news is that we can create our own village if it doesn't look like the traditional one we might be used to seeing. Having someone you can rely on and trust in your corner is always a positive support. Compassionate care and screening from providers. Unfortunately, less than 20% of moms and birthing persons are screened and assessed for perinatal mental health complications. If we don't know there is a problem, we can't get the support we need. Compassionate care and increased screening from providers is essential to next steps in accessing quality care and treatment. Screening and assessing for perinatal mental health conditions may sound intense or scary, but it's actually quite simple. Anyone can screen for PMHCs. Screening is the first step in identifying those at risk for PMHCs. It's an opportunity to learn more about someone because we don't always know how someone feels by how they look. Screening is accessible and it can be administered by anyone. Commonly used screening tools such as the Edinburgh Postnatal Depression Scale can actually be found through a quick Google search and downloaded as a PDF. Screening is best implemented early and often. This might be a screening during each trimester during the prenatal period, as well as every month or baby well visit, maybe by a pediatrician, for the first 12 months postpartum. Screening is really most effective, though, when administered in an environment of trust and safety. So having a conversation with someone, making sure that there's trust, rapport, that you have shared language, you're able to tailor the conversation and personalize your questions. That is what is going to make screening the most effective. Screening is not a diagnosis or a one-time assessment. As I shared earlier, screening is best done early and often because we know that feelings and emotions and things can change throughout the perinatal period. Screening, unfortunately, is not universally mandated. So right now, less than 20% of birthing persons are screened for PMHCs, and this is because we don't have a standard protocol or practice across providers that says that we should screen or how we should screen. Also, screening is not necessarily validated across cultures. So while the screening tools like the EPDS or the Edinburgh Postnatal Depression Scale might be translated across different languages, that translation doesn't always relay the way that we talk about mental health. And so it's not validated across cultures. Screening also is not particularly useful in identifying risk outside of depression or anxiety. This is due to the history and work and development of screening tools, really not understanding the full spectrum of conditions that can occur during the perinatal period. So they weren't created to detect things beyond depression or anxiety. And for those of you interested in understanding screening and perinatal substance use, it's also really important to note that screening is not interchangeable with urine toxicology with regard to substance use. The Pregnancy Associated Mortality Review Board, established by the Ohio Department of Health and the Ohio Department of Children and Youth, published a report from 2020 that stated that inadequate risk assessment was a leading contributing factor to pregnancy-related deaths in Ohio. So when you think about it, improved screening rates and practices could significantly improve the number of moms and birthing persons who are able to access quality care and treatment.
Listed on the screen are examples of screening tools for perinatal mental health and substance use. I think it is important to note that screening does not have to be complicated. You do not have to use any of these screenings. If you already have intake assessments or other paperwork that you complete with patients or clients, you can simply add questions in language surrounding perinatal mental health, substance use, and trauma to your existing paperwork. It doesn't have to be difficult, and you do not have to recreate the wheel.
As we wrap up part 1 of this training series, remember that perinatal mental health complications are treatable, and early detection is key. Remember to be aware of the risk factors, observe behaviors, actively listen, administer informal assessment, refer, and follow up. The best practices for referral and continuity of care are rooted in compassion and humility. Always discuss all treatment options with the mom or birthing person. It should be their choice to engage in care that feels right for them. Connect with community health workers, midwives, doulas, or other peer supporters in your area so you can best know what resources are available in your community and accessible for whomever you're supporting. Develop partnerships with mental health and support service providers to enable warm handoffs and wraparound support. Peer supports and mental health providers are not in competition with one another. Each plays a distinct and important role in the care of moms and birthing persons. Work together to ensure connection to care is made within 1 to 2 weeks of a referral. This is a critical step in building trust with moms and birthing persons. If you are able, ensure moms and birthing persons attend their appointments. Don't be afraid to contact them when they miss, not with judgment or criticism, of course, but with understanding and willingness to help them figure out a plan to get there. Be reliable, consistent, and transparent about your capacity to support. If you or someone you know is in need of support, you can contact POEM. POEM is Mental Health America of Ohio's peer-led perinatal mental health support program. All of our services are delivered by moms and birthing persons who have lived experience with perinatal mental health complications and are now in recovery. We provide direct peer support, education, resources, and referrals for Ohio moms and birthing persons during pregnancy and early parenting. While postpartum might be defined as 1 year following childbirth, we recognize that perinatal mental health complications may not resolve within 1 year, and we often work with moms and birthing persons for as long as they need the support. We offer a voice and text support line Monday through Friday from 9 to 5, weekly support groups, both in person and virtual, peer mentorship, referral to mental health providers and other community resources, perinatal mental health education and advocacy through the Ohio Perinatal Mental Health Task Force, and culturally matched and equity-focused care through our RISE branch. RISE is a branch of POEM that is by and for Black moms and birthing persons. To learn more about POEM and our spectrum of services, please call 614-315-8989 or email poem@mhaohio.org. Thank you.
As I mentioned in my introduction, I operate CompDrug's Perinatal Linkage to Care program. This is a Franklin County specific program designed for perinatal people with a history of substance use, mental health concerns, and housing instability. This program connects people to treatment, resources, and support that they need to be a mother as well as a fully functioning adult. This program prides itself in using a trauma-informed approach as well as a harm reduction approach. Anybody in Franklin County can make a referral. The referral information is listed on the screen.
Ashley and I thank you again for joining us for Part 1, Perinatal Mental Health 101. For continued learning, head on over to Part 2, Peer Support in Perinatal Mental Health, where we will dive a bit deeper into the ethics and boundaries of peer support, as well as strategies for care and treatment of PMHCs. Thank you.